how we do that remains to be seen, and it's going to be different for different systems. But the key in this will be partnerships. And to end with, us to think about how do our systems learn from technology and data. It's an iterative model. It's test, retest, test, retest. But we should have a system in place that we're able to do that effortlessly. Trained people, clinicians, non-clinicians, nurses, that are able to lead that type of learning for our clinics and our health systems, and therefore we need to invest in them, right? And in a relatively short time period for them to be able to do that. So I took out a whirlwind a little bit. I hope it was useful, but I thank you very much for your audience, and I'm especially looking forward to the hands that go up. Yeah.
I'm Terry Offenberg, SCAM director. What was driving your reduction in readmissions? Is it all related to this $25,000 pulmonary artery pressure device?
That's a good question. We know that the readmission rate, what it is not per patient. Right? One individual might be generating an outlier, but drives up the readmission rate. So it's a combination of several things. One, the sensor in high-risk patient populations, but right now we've only implanted about 125. So moving the needle on 125 has shown percentage reductions, but it has been a heart failure center of excellence. This is PAs, nurses, NPs, 4 cardiologists, and to create a node between our five system integrated yet dissociated healthcare system. But it was 7-day follow-up after readmission was absolutely necessary. Early deployment of home care at the time of discharge. And the last one was pharmacy follow-up to ensure that medications were filled, afforded, and compliance is something we're working on. But these were some of the larger steps. The other ones were telemedicine visitations, because it harnessed patients felt secure when we did that. It won't change a readmission rate, but it did empower patients and caregivers. So I think as we look at it as the whole on that number, we had to see it from several different slices of that pie. But the thrust of it was restructuring the heart failure clinic. And a big component of that is how cardiologists and primary care physicians identify heart failure. There's a lot of training over the last decade. So moving from many perspectives. And La Jolla is different than county.
Could you say your name and institution before your question? And then can you repeat the question unless the microphone gets to you?
Sure. Diane Sokol from PIH Health. I just wanted to piggyback on that question, and you've answered follow-up 7 days. Is that, because we are implementing a CHF program for readmission as well, and one component that's missing in ours is a pharmacy component follow-up, but for the 7-day follow-up, you're talking about cardiology follow-up.
Cardiology for the highest risk patients, if you'd like to. It's hard to get into cardiologist's office that soon. But sometimes there's primary care physicians as well. Okay. We built out in the state of Connecticut, when I did my training, we had a 7-day bridge clinic. And it was a 27% readmission rate. Hartford is like LA, is just smaller. It's a smattering of populations. And so it had staffed a bridge clinic that had individuals come in even 3 or 4 days after their discharge. So, but it was an institutional redesign. And in that, we have not done this at Scripps, but in Connecticut what we did was we had a Idi Rescue program. So if someone was flagged as at risk of a 30-day readmission because they ended up in the ED for a fall or pneumonia or heart failure, that a rounding cardiologist, then it turned into an NP, would go down to the emergency room to see that patient before they were admitted. And so it rerouted that individual, sometimes to an infusion clinic, sometimes to home care, sometimes to palliative care, or to the bridge clinic. So it was not a precise science, but it required resource allocation, and so it was successful in reducing the readmission rate from 27% to 18%, and so it rolled out statewide.
Thank you. So I just want to throw out for folks that in LA, the rate of heart failure readmissions is higher than the state. And that Dr. Bhavnani's clinic, his innovation clinic, it has about a 20% fewer rate of readmission. So 29% LA, 7 to 9% at his clinic. So can you talk a little bit about what you see as the key features for the better outcomes there at that clinic?
We have to look at that with a whole spoonful of salt. That even across the Scripps system, Scripps goes down close to the border, right? The Hispanic patient population in Chula Vista, pretty underserved, and their readmission rate is still hovering at 25%. We go up to Encinitas, it'll be about 17%. Now at the Node, which is the heart failure clinic that has abundant staff, right? It has abundant resources, and it's been designed that way over a decade. It has a 9 to 10% readmission rate. But there's many other things that go into that. That node might have a high preponderance of insured patients, right? Compliant caregiver support. So there's many other things that go into it. Although it's really good, Tom Haywood doesn't highlight it as a model for excellence. What it more is a model for how clinics are staffed and trained to manage complex heart failure. Right? So I think from that, the takeaways from our clinic are train people and get people. Right? It's hard to hire PAs, nurses, and NPs. They're very expensive. Right? But if we look at the model on costs and readmission penalties, some institutions will do that equation and say that having an extra NP in a bridge clinic or a heart failure clinic will help reduce 30-day readmissions.
I'll wait for
And as you're waiting, something to think about too, there's a lot of recent literature to show that 30-day readmissions and the increase in mortality. As Greg Fonerow and Harlan Krumholz are asking this, was it even the right measure to have measured? So.
Can you elaborate for a moment?
So Fonerow published in JAMA, in his group, 2 months ago, maybe 3 months ago, that those areas and centers that had seen the greatest 30-day risk reduction had the greatest 30-day mortality rate and 1-year mortality rate. Well, people are still living, and they're going to die one day, right? And with heart failure, we know that the mortality can be 30 to 50% 1 year, depending on risk. But in the data, it also showed, well, the quality of care for 30-day readmissions had not gone up. So observational care that emerged over the past decade may not have he says, did not result in the improved quality because it just triaged people quicker out of the hospital. It's a very well-known statistic. Shows the longer the hospital length of stay, the shorter the hospital length of stay, the greater the 30-day readmission rate is. If you're discharging people from the hospital before they've actually gotten better, they're only going to come back, whether you get them into clinic 7 or 14 days later. So, but administrators and CMS and others hadn't grabbed onto that data, and that data is over 10 years old. So, in 30-day readmission, as of the last 4 or 5 months, is a highly contested quality measure that has emerged through CMS and the literature.
Hi, my name is Janina Morrison. I am the Director of Clinical and Preventive Services for Chronic Disease and Injury Prevention at the Department of Public Health. It's a very long title. Thank you for your patience. So in terms of the staffing up the team and the cost, I'm really interested because in the county system, we are staffing up with community health workers, with patient navigators. Is there any middle ground between some of the work that you're extra clinicians are doing that could be done by a lower cost team member?
Yeah, so, actually you alluded to that as we were discussing. The chronic care, so one thing we've done is the chronic care management program. That this is a Medicare specific program of nurse-driven virtual care. So patient at home, nurse in the clinic, 20 minutes per patient per month. Medicare beneficiaries. The Connect legislation will roll it out for Medicaid next year. But it is using the workforce now for longitudinal care, and that can be reimbursed. So my nurses in clinic, and Dr. Haywood's nurses in clinic, are furnishing chronic care management by calling or using a Skype-like platform, and to go over a plan for that patient, your heart failure, your sleep, your medications, how are you feeling, whatever is important for that individual, documenting it, and then billing for it, between $60 and $110 per patient per month. So there's a tool there now. Medicare released it in 2015, and it just got revamped in 2018, January. So it's something for clinics to start using their staff in a different way. So it's a good program. It looks like it's here to stay, because they've made it easier. You don't have to inform consent patients into it anymore. The copay for patients, which was $8 per month, is now, it's not there. The reimbursement has gone up from $40 to up to $110. So there are incentives for clinics to use this. It's the Medicare program, but watch out for it for Medicaid next year.
Christine Castano from Healthcare Partners. I have an observation. We had tried some of the technology, particularly the scale ourselves, and found much the same, that it didn't improve outcomes in the way we wanted. But I had a question about the MEMS device. Have you had situations where the data from that device has helped you at that inflection point between aggressive care and realizing that further care is futile and putting the patient into palliation?
Yes, absolutely.
Great question.
Absolutely. You can change what you can, but the data itself sometimes gets practitioners to think differently. Things can't be monitored in the dynamic paradigm of heart failure. Volume and pressure are only one thing, right? So yes, although it's used in the highest risk patient, this is also the group that we should streamline when we need to palliative care.
Okay, Margaret Maglioni from RAND has a question.
Thank you. Well, I have two questions. Well, the first is about the cardio MEMS. Is that only covered by insurance for level 3 and 4 patients?
For
CHF?
class, no, it doesn't differentiate based on class.
So you
Someone
can be
has-
in class 1 or 2 and,
So it's that they had a hospitalization within the last 12 months.
okay, I just
So
wanted to check. 'Cause
it was that criteria, and it's not systolic heart failure or diastolic, it's any heart failure.
Okay. And then the other question was about if you had any data or results on the text messaging for reminders on medication, because to me it seems like if it were me, I would just block them.
Right. So yes, it was HIV patient population in San Diego, and looking at viral load suppression with text messaging. And in this group that has a non-compliance rate that can sometimes be 100%, it showed that text messaging at 6 months, this was colleagues in my wife's group, that showed that text messaging can result in an increase in medication compliance of 50 to 60%, and in that group, viral load suppression. Other groups have come up with hypertension monitoring, and have shown that at 6 months, again, these are short-term outcomes, that text messaging can result in a systolic blood pressure reduction of 4 to 6 millimeters of mercury. Text messaging for diabetes can result in an HbA1c reduction of 0.7 compared to standard of care. So, although these look like pebbles in the pond type of changes, text messaging is ubiquitous, scalable, and it's nearly free. So as much as we talk about technologies, if I could create a system-wide robust text messaging program, I'd do it.
So one of the things that our group is interested in is prevention of heart failure as well. Can you talk about early diagnosis and interventions that might slow progression?
Right. So this is actually where lifestyle and technology might actually come together. So the ACC, AHA, the HFSA have identified that if any individual has hypertension or diabetes, they are at risk for heart failure. Excuse me. So if we use that group, they haven't had heart failure, it may be a decade before they develop heart failure. So how do we prevent it? That's where guidelines and then clinics use lifestyle modifications. So I say it to my patients, and diet, exercise, sleep, stress reduction. And, I don't think I do one of them well, but you know, these are challenging as well, right? Healthy diets are very expensive. Everybody's under stress, financial constraints, the list goes on and on. So, you know, prevention, heart failure gurus would say we should prevent heart failure, but how do we do that, right? And I think each of us will have our own perspectives on what that is. I'll take the technology perspective for that. You know, activity monitoring can be very powerful, but we have to be creative in how we use it. So as an example, we've done trials that have given activity monitors to healthy people, and they stopped using it. And then we gave activity monitors to healthy people and their spouse.
Mm-hmm.
And then we found engagement at 1 year, ongoing use, step counts that went up and stayed up. We've used incentives that if you reach 10,000 steps, your copay is waived, or we'll give you $20, right? Starbucks gift card, right? Didn't work. Right? So we had to look at different engagement strategies for something that should work, but again, the technology itself is not the only factor. I think you asked me before what my wish list would be. That would be, you know, 3 healthy meals in a day, right? To people who have hypertension or diabetes, but can't get it. Now, I think that would be preventive, right? Making sure people have food security. These are big things now. Right? But I would be interested in your guys' inputs from your perspectives on how you prevent heart failure. Right? But I think it's a moving target.
Since we do have some insurers in the room, can you talk about some of the challenges that you've been having with managing your patients related to coverage?
And so it's, every clinic has this problem, right? Medication coverage, especially for the newer heart failure medications, particularly Entresto.
Entresto.
Yeah,
We
Entresto.
had a patient readmit because he couldn't get it.
right? And so we have the same problem, whether it's commercial insurance or Medicare donut holes or you know, Medicaid or uninsured patients. The medication works. It's not the fault of the pharmaceutical company. They just came out with this. But how do we know that there's a benefit, and a staggering one. So how do we accelerate its use for clinical care? Right? And cost is simply the factor. How do we reduce that? So if the insurers were willing to reduce it but maybe provided that there's a measurable outcome that they can see. Maybe it's tied into medication compliance monitoring. Novartis has approached us with how can you ensure that this medication is taken? Right? And it's a good question because maybe insurers they've gone to insurers and that was the response. But it'd probably be much more than just reducing costs. The pharmaceutical industry is going to look at it and say, well, what's my return on that? So, I don't know, your guys' perspectives again. There's varied citizens in the room on how would we do that. You know, healthy meals, tobacco cessation, incentives towards medications. You know, all of this goes into it, and that's why it's so interesting. But I don't know how we get there.
Could we have Bahar Davidoff elaborate on that case? And would you mind bringing me the microphone? Or, sorry. Bahar is in purple there. You just exclaimed some experience with your HF patient. So Zaher is a senior pharmacist at Regal Medical Group. She's been part of the RightCare family for a long time.
So we have 500,000 lives in Southern California, and what we take risk for is the institutional and the professional side. So we had a patient that discharged from the hospital with a prescription for Entresto, went to the pharmacy and got denied. And we were trying to get it, to do the prior authorization with her PCP, who she was going to see within 72 hours. Unfortunately, they wanted a cardiologist, and we couldn't get a hold of the cardiologist that was going to see her, and we couldn't get a hold of the one in the hospital. So she went without the medication and readmitted within 3 days. And we had another $12,000 charge, because every time we have a heart failure patient readmit, it's 3 nights stay at least.
Were there any other things going on with that patient? Because one medication that they
Well,
weren't
the
taking.
PCP changed it to losartan, and we said change it to valsartan. He changed it to losartan, but I think she needed to be stabilized in the hospital, probably on the Entresto low dose, and then brought to the higher dosages. So there's a lot of gaps in care, and although the cardiologist saw her in the hospital, recommended the medication, she wasn't able to get it, and we had the readmission happen.
Right.
We also did a lot of telemedicine with a lot of our patients, but we didn't risk stratify like you did with the class 3 and 4 and only 6 months. So I think that's where we didn't see the benefit, so I was going to take that back and put it in our protocol, so thank you for that.
Send you a paper when it's ready.
Oh, thank you.
The question you had with the big circle, I mean the presentation with the big circle with all the elements involved.
I'm really interested in the one little aspect of that circle, which is the artificial intelligence, and which has to do with putting all the big data together and getting the HAL from 2001. Not to say I can't do that, Dave, but to actually do something. Can you just briefly talk about where you see AI and how fast it's going to accelerate and maybe help us in our decision-making process and our care processes?
Absolutely. So it's a very good article in last week's JAC on artificial intelligence in cardiology, written by the premier group out of Mount Simon, explaining what is AI and how are we going to use it in healthcare. So just in a really broad way, all it is this advanced. It's an advanced statistical methodology to be able to infer prediction. So how does it do that? Let's say it uses a lot of data on one hand, and then it correlates it to a gold standard. Okay, now let's use a gold standard being coronary disease. Well, at the time of an angiogram, we're diagnosing coronary disease. That's the gold standard. Now, if you have all this data up front, or you've used new technologies, or whatever they are, you have all this data, and then you have a dichotomous variable. Okay, you have yes coronary disease, no coronary disease. And then you apply it into this algorithm that keeps building upon itself. It's similar to a logistic regression model. Multivariable model is very similar to that, but it has other nuances in it, and with how it creates prediction, and then it goes back, puts another variables into it, and compares it to another model that it created. So it's dynamic in that, but where it uses a gold standard, and I think for the statisticians in the room, they say that's great. It uses a gold standard. Even that gold standard is not dichotomous. Yes coronary disease and no coronary disease is still 20, 50, 70, 90% coronary disease. So it's a very good paper. Is AI here to stay? Well, the FDA approved five AI algorithms to detect disease within the last 12 months. And one of them was diabetic retinopathy. You give a machine the ability to interpret retina of a diabetic patient, and it can predict diabetic retinopathy far greater than the human, the physician interpretation. So they did the gold standard assessment, submitted it to the FDA, and got it approved. So that means there's an algorithm available to use. How institutions get that algorithm is a different story, right? But when we say where are we with it, we're still very early, but we're already beginning to see where it can be. The next phase is where it is right now is radiology. X-rays can be interpreted by machines, so radiologists have to be very worried about their jobs. But a great article if you guys are interested, very easy to read.
So I have to say that we're at the top of the hour. I think everybody is just so loving your presentation that nobody wants to leave, but we have to honor everyone's schedules. This is our normal time that we break. And so anyone who wants to continue with Q&A, Dr. Bhavnani needs to leave at 3. And if anyone wants to try the Cardia device, we can do that after we break. So thank you for being here. We'll see you here third Thursday of the month next month. Thanks for being here.
That's something you didn't even touch on.
I've actually come over to you.